Okay. Great, it's 8 o'clock. Welcome everybody to Grand Rounds. We are kicking off October. Hard to believe it's already October. Before we start, I do want to give a reminder that next week's town hall on Wednesday evening, we will be talking about wellness and burnout. Mariah Quinn's going to be presenting the results from the Department of Medicine recent survey. So please make every effort to attend. And I actually think that's a fitting segue into talking about stress today, perhaps a different type of stress. But I'm absolutely delighted to have Nicole Reilly here. And to introduce Dr. Reilly, we have Dr. Mohammed Hamdan, who is the Division Chief of Cardiology. Dr. Hamdan.
Thank you, Dr. Schnapp. It gives me great pleasure to introduce our speaker today, Dr. Reilly. Dr. Reilly went to medical school at the University of Wisconsin School of Medicine and Public Health, and she stayed here for her internal medicine residency and fellowship in cardiovascular medicine. During her last year of training, she served as chief fellow, and in 2017, she was appointed as assistant professor of medicine on the clinical track. In a very short period of time, Dr. Reilly established herself as an outstanding cardiologist with passion for teaching. She has given several departmental regional talks on topics related to non-invasive testing for coronary artery disease, as she will do today, hypertension, and women's cardiovascular health. She has also been involved in classroom teaching, helping with the body imbalance cardiovascular course since 2017. The best way to gauge how good of a teacher you are is to look at your evaluations. And Dr. Reilly's residency evaluations were simply glowing. So I want to share with you just one comment that I think summarizes her approach to teaching. She always checks for understanding of new concepts and makes sure you really get it. She takes time to teach, even on busy days. In addition to being a great teacher, Dr. Reilly also has been a great citizen. She has served on several committees, including the Cardiovascular Medicine Quality Improvement Committee. And more recently, she has been a core faculty member for our fellowship program. At the national level, she's a member of many societies, including the American College of Cardiology, American Heart Association, American Society of Nuclear Cardiology, Society of Cardiovascular Computer Tomography, and American Society of Echocardiography. She's also a member of the AHA CLDC Fellow in Training and Early Career Committee. CLDC stands for Council on Clinical Cardiology. And that's really a privilege given only for a few. So today, Dr. Reilly is going to be discussing her favorite subject, stress test, eliminating the stress from stress test, non-invasive evaluation of coronary artery disease. Dr. Reilly.
Thank you so much. Good morning, everybody. That was such a nice introduction. Thank you. I appreciate that. It is one of my favorite subjects to talk about, and I think it's because we see this every day. And if I can make it less stressful for everyone else out there, then I think ultimately what we'll get is better patient care, which is what I think we're all here for. So I'm sure we'll be getting chat questions coming in, and I'd be happy to address those towards the end of the talk. I think that if this information for the sign-in is needed, we'll be able to get that to you later as well. So here is the disclosures and objectives for today. And so my goal today is to get rid of the stress for when you're trying to decide what sort of non-invasive test are you going to use to evaluate for coronary artery disease. So I chose a few key objectives that hopefully as a result of this lecture, everyone's going to be able to take away. Identifying patients who can benefit from non-invasive testing for coronary artery disease diagnosis, discussing some of the differences of the non-invasive tests, explaining the contraindications for stress testing, utilizing our guidelines and appropriate use criteria to really choose the optimal non-invasive evaluation for coronary disease, and then interpreting some of these non-invasive test results. There are so many types of non-invasive studies. It can be overwhelming, and picking the quote-unquote right test can really be challenging. ultimately, what we're striving to do is to find the right test for our patient that's going to improve his or her outcome. And why is this important? Well, I think everybody kind of understands that heart disease is the #1 cause of death in the United States. There's millions of adults in the United States with heart disease, and the burden is just so high that having the knowledge and power to pick a test that's going to help your patient is very important. And this is an old statistic, but there are millions of stress tests ordered per year in the United States. So a huge volume of testing. Let's make sure that we're getting it right. And I think taking it back to the patient, we need to know that the symptoms of heart attack or coronary artery disease are not always chest pain. Many times, especially in primary care offices, patients come in with pressure or tightness, or they just have this strange fullness in their chest. Maybe it's an ache. Maybe it's simply difficulty breathing. And these are all symptoms that we can have non-invasive testing to help us evaluate. So when we think about some of the common indications for non-invasive testing, I kind of tried to lump this into a few categories. 1, patients having symptoms that you're worried about coronary artery disease. So we're trying to make a diagnosis. Is that diagnosis an acute coronary syndrome? Or is that diagnosis stable coronary artery disease? If you have a patient that already has known coronary artery disease, and perhaps they have new symptoms, then really what we're evaluating is more of a prognosis. We're trying to risk stratify those patients who's going to benefit from invasive evaluation. Other times, we're looking to stratify someone's risk preoperatively. But the bottom line, I think, when we're ordering a non-invasive test from a cardiovascular standpoint is, let's make sure that this test is going to change our management of the patient. So this is a very busy slide, and I know we're supposed to stay away from busy slides. I bring it up simply to show that in 2019, many of our large societies came together for a joint appropriate use criteria document that goes through all of the different multimodality imaging for cardiac evaluation. And this is structure and function for non-valvular heart disease. There's separate guidelines for valvular heart disease. But a lot of what this goes through is transthoracic echo, stress echo, nuclear stress testing, coronary artery CT, invasive angiography, and really the times when it's appropriate or rarely appropriate to order these studies. And a few of the indications that are really rarely appropriate to order stress testing I've listed here. Things like just an incidental right bundle branch block or a new diagnosis of hypertension. So I include this as we're thinking about why are we ordering non-invasive testing? How is it going to change what we do with the patient? And if you're struggling, this is a great resource to go back and look at. So these are the questions that I try to ask myself, and I hope that all of you would ask yourselves as you're considering what test to order. What is this patient's pre-test probability of coronary artery disease? And we're going to get into that in the next few slides. Is this test going to change my management? I'm probably going to say that a lot today. Is the test I have in mind appropriate for this patient? Are there contraindications to this test? And we'll get to that in a minute as well. Does one testing strategy have better patient outcomes compared to another? Can I minimize the amount of radiation to this patient? Are there testing strategies more cost-effective than others? So when we think about those questions, maybe let's take a step back and say, well, what in the world is stress testing? So traditionally, we think of stress testing as functional testing that can non-invasively evaluate for the presence of obstructive epicardial coronary artery disease as the cause of a patient's symptoms. So we're using it as a functional measure to see if there's blood flow restriction in the coronary arteries that explains their symptoms. Many times people think of this as, okay, I'm going to get the stress test and it's going to tell me cath the patient or not cath the patient. But I would posit that it's not always that simple. It's not always a negative or a positive test. And a lot of times patients will come in and they'll say, yeah, my primary care doctor referred me because I flunked my stress test. Well, it's not always a pass versus fail. There's a lot of information we gather from it. So when we're using stress testing or other non-invasive cardiac tests like cardiac CT to evaluate for the presence or absence of coronary disease, I think it's very helpful to know before you do the test, what is that patient's probability of coronary disease? And that's where taking a really good history using ECG, and if they're in the emergency department, urgent care, troponin levels. For patients who have a really low pretest probability, we generally think of that around 10% or less. High pretest probability is greater than 90%. So the intermediate group is a huge group, and those are the patients where testing really can change their post-test probability of coronary artery disease. So before we order a test, thinking about contraindications to stress testing. Some of these are pretty obvious, but some of them are less obvious. And so I think it's worthwhile to just make sure that we refresh ourselves on this. If someone has had an acute myocardial infarction in the past 2 days, probably not very helpful to stress that patient, and you could actually cause harm. If you really truly think that patient has unstable angina, high-risk symptoms, angina at rest, probably not the best person to do a stress test on. Another one would be uncontrolled cardiac arrhythmias. So I'm thinking here, atrial fibrillation, really rapid ventricular response, hemodynamic compromise. So they're hypotensive, heart rates in the 150s. That's not somebody we're stressing. Active endocarditis is a contraindication to stress testing. If someone has truly severe aortic valve stenosis and they're symptomatic, you could cause harm by stressing that patient. Acutely decompensated heart failure, acute PE. One that's less well recognized, but still a contraindication to stress testing would be acute myocarditis because of inflammation and risk of arrhythmia. And of course, we want to make sure that our patient can follow directions and is physically safe to do stress testing. So there are some baseline ECG abnormalities that can obscure changes during exercise. And that would require, in addition to ECG data, imaging data. And I think those are pretty well known, but to review, left bundle branch block, if you have left ventricular hypertrophy with repolarization abnormalities, digitalis effect, pacing, or pre-excitation. So starting to get now kind of into the meat of the talk, where we're thinking about all of our different strategies. I put this together because I know some people like to learn visually, and I know some people like to learn with algorithms. So at the top, I've listed functional versus anatomic testing. So those are the two main groups or buckets of ways we can evaluate someone for coronary disease with non-invasive testing. So I talked about the definition of stress testing or our functional testing. And that can include exercise as the modality of stress, or pharmacologic means, either vasodilators or medications like dobutamine, which increase heart rate, increase contractility. When we do those types of functional testing, we can do them with the ECG alone, or if there are baseline ECG abnormalities, like we just went through, we can add imaging. We could add imaging like nuclear imaging, echocardiogram imaging, and get a combination. And then if we're thinking about anatomic testing, if you think back maybe 20 years ago, the only anatomic testing we had was invasive coronary angiography. Now we have non-invasive coronary CT angiography. So we can non-invasively, meaning no procedure to the patient, evaluate for the presence of coronary artery disease in an anatomic fashion by directly imaging their coronary arteries. And I put a little asterisk here because we will have functional testing from the coronary CT now as well. And that's called CT-FFR. And we're going to talk a little bit more about that coming up later in the lecture. But this is a way to actually combine both anatomic and functional testing, which can be very powerful. So for the people who don't learn well from algorithms, I put together a chart. I was a big person who learned from charts going through medical school and residency. So I've listed the modalities that we can use to non-invasively evaluate patients on the left, and pros and cons. Things that we can think about that would make it relatively preferable to use one modality versus another. Things like ease of use. So a treadmill ECG alone, pretty straightforward to do. No radiation, but not all patients can exercise. Stress echocardiography is great because we don't radiate the patient. We get imaging data on top of our ECG data, but sometimes our image quality is limited. Nuclear imaging has been the workhorse for a long time for non-invasive testing. You have the options of exercise or medication to stress the patient. You can really well quantify the amount of ischemic myocardium, but there's a lot of radiation that patients get with this. Cardiac CT has a lot of pros to it. There's good spatial resolution. We can see the coronary artery. The sensitivity is very good with very high negative predictive value. And like I mentioned, we now have the ability to get functional data from that with non-invasive FFR. The main drawbacks are some radiation, although this is less than with nuclear imaging, and we use contrast. And then there's also cardiac MRI, which offers even more information, things like tissue characterization. We can get wall motion and perfusion information similar to nuclear imaging. But right now we're not able to stress people with exercise as a modality of stress. And I think thinking about all of these test modalities and going back to pathology, pathophysiology for why these things are helpful can make a lot of sense. So what we're trying to do, thinking back to the beginning, is we're either trying to make a diagnosis of coronary disease or prognosis for patients who have known disease. And the different test modalities have different test characteristics, different sensitivities, specificities, and that's related to what they're testing for. So if you're looking for perfusion abnormalities, that's going to be a more sensitive test because we're detecting ischemia, which comes early in the ischemic cascade, versus looking at mechanical changes, wall motion abnormalities, things that we would find with stress echocardiogram. That's going to be slightly less sensitive, a little bit more specific, because this falls down further on the ischemic cascade. And even farther down are ECG changes in angina. So treadmill testing alone is going to be one of your least sensitive ways. Okay, so that's kind of the background information, the foundation for what we're going to go into. I don't know about everyone else, but I know COVID's been really impactful on everybody this year. We're missing the Olympics, and this is Katie Ledecky, one of the Olympic swimmers, and I just thought we should dive in, so in case we're missing swimming. So I've included some poll questions to help keep everyone engaged today, and I'm really hopeful the technology works for us. So I'm going to put up the first question. Let's just see if this works for us. Oh boy, it's not going to work. All right, I'm going to try it one more time. If our live poll doesn't work, what I'm going to do is I will pull up the questions so that everyone can see them. So it really isn't liking it. So here's what we're going to do. I'm going to pull it up this way. Is anyone there that can chime in to see if they can see this quiz question?
We can see it.
Okay, great. So apologies for the technical issue. It did work on my practice run, so who knows? 2020. Okay, so the first question is someone that you might see in clinic. 43-year-old female who has hypertension, and she walks 2 miles a day with her dog, and she's asymptomatic. And she's coming in for a routine follow-up in clinic. So which of the following would be a reasonable thing to do for her for next steps in management? So I know I'm not going to get live poll information. Just in terms of the chat function though. Clint, are you seeing anybody chime in via chat?
Sorry, needed to unmic myself. Yep, we're getting a number of E's.
A number of E's. Okay, fantastic. So that's the right answer. Good job, everyone who voted for E. And one of the things that you could consider in terms of not testing her is, depending on what you're doing for the visit, a calcium score by itself, which is not a stress test, not looking to diagnose necessarily obstructive disease, but that might be the only answer that could be considered besides the top three. And the reason to do that would be for an asymptomatic patient who you're trying to risk stratify in terms of primary prevention, in terms of helping that patient decide, do we need to intensify either lifestyle modifications to lower risk, blood pressure control, lipid control, statin therapy. So for our asymptomatic patients, yes, we are not stressing or evaluating them, but if you're thinking shifting gears a little bit to primary prevention, that's when a calcium score might be reasonable. And I'm just going to stay in this mode since the polls are not working. But the next question to help think about what tests we're going to use. So a slightly different patient, 62-year-old male who smokes, he's having chest heaviness and dyspnea when he climbs the stairs. I'm going to give everyone a chance to think about this. Would you send him straight to the cath lab? Would you do a coronary CT? Would you do a stress test? Either echo, exercise, dobutamine. Maybe you're just not sure and you're like, I'm scared, I'm going to send him to the ER. So maybe Clint will give 20 seconds or so, and you could just shout out some of the answers that we're seeing.
Yep, exercise EKG, cath, C, CT, farm test, stress test, exercise stress test, C, stress echo, C, cath. Exercise stress test.
Okay. So when I think about this patient, I think it's really great, everybody who's volunteering answers by chat. Thank you so much. I see somebody whose pretest probability of coronary disease is probably pretty high. Many risk factors, tobacco use, age, gender, and pretty classic symptoms. And so what we're trying to do with this patient is we're trying to make a diagnosis. Are his symptoms due to coronary disease? And I think that a good way to evaluate his diagnosis and then prognosticate is with stress testing in this circumstance. And so probably I'd be inclined to do an exercise stress test, and I would want some imaging to help me further evaluate his risk. And so likely what I do if he's able to exercise, which it sure sounds like he is if he can climb up the stairs, is to do an exercise stress test and probably pick echocardiographic imaging, because what we can also get with that is, in addition to wall motion abnormalities and ischemia evaluation, we can actually look at diastolic function and see if the dyspnea might be related to that. So I think that test would probably be the next best test to get for this patient. And so when we're trying to stress someone, if we're going down the functional route, when we have the opportunity, we should exercise them. That's our modality that is preferred for stress. And what we're trying to do is achieve a heart rate goal of greater than 85% of their age predicted maximal heart rate. So if you're seeing reports come back saying test sensitivity reduced, only achieved 75% of heart rate, patients aren't getting up to the level of exertion that could be maximally stressing them. And the reason that this is important is because if you go back to the 1980s, in the Annals of Internal Medicine, the original publication on the Duke treadmill score was published. And what this was 2,800 patients who had chest pain, and they underwent exercise treadmill testing, and then they followed that up with cath for all of those patients. And based on the patient's ability to exercise on the treadmill in terms of exercise time, ST segment changes, and angina, whether that was no angina, non-exercise limiting angina, or exercise limiting angina, they came up with a score and used that score to help predict long-term survival. And the patients with the high-risk scores in this dashed line here, survival here along the y-axis, time along the x-axis, those patients with high-risk treadmill scores did a lot worse than patients who didn't. And this is really one of the key trials that gives us good data to help with exercise is such an important prognostic factor. So that's why whenever we choose functional testing, if we can exercise the patient, that's going to be most fruitful in terms of the information we gather. Now, exercise is also not the end-all be-all of non-invasive testing, but it's really important. It's an important part of our toolkit. And so when you get those results back, I want everyone to know what are high-risk findings. What should make you be more inclined to refer to see one of us cardiologists is if you have big ST segment changes. ST segment changes at low workload, like if they're only 3 minutes into their exercise and they start having 2 millimeters of ST depression, that's worrisome. Certainly ST segment elevation is worrisome. And then that treadmill score. So if they have a lot of exercise-induced angina, those big ST segment changes, short exercise time, that all combines to a high-risk treadmill score. And those are things that we want to pay attention to. So in our patient, we also decided that we were going to maybe get some imaging. And that could be all kinds of imaging. But first, let's talk about stress echo. So with stress echo, recall as I showed from that flow diagram earlier, that we can either use exercise or a medication such as dobutamine to simulate stress. Some of the pluses to getting stress echo are that we get ECG data plus the imaging data. We can look at the left ventricular global function and regional wall motion, both at rest and with stress. And you're going to see words like akinesis or hypokinesis if the stress test is abnormal. There's some new research coming out about vasodilators and coronary flow reserve that can be used to look at stress perfusion in echo, but that's not widely in clinical practice yet. So if you send someone for a stress echocardiogram, what are high-risk findings on that that should be addressed sooner rather than later? That would be if there's a new finding of left ventricular systolic dysfunction, if there is stress-induced left ventricular systolic dysfunction, so that ejection fraction drops from the baseline. If the left ventricle gets bigger with stress, that's an abnormal finding. If there's large areas of segmental dysfunction or areas that is suggestive of more than one coronary distributions. And this should all be detailed in the summary. These are things that we should make a point to you to say that this is abnormal and this is high risk. So we're going to go back to my failed poll questions, and we're going to bring up another one here. Okay.
Anybody?
Right. Okay. So this is a 75-year-old man. He's coming in, he's got a known history of coronary disease. He had PCI about 3 years ago and went through cardiac rehab, did well after that. And he's coming in for his routine yearly follow-up and he's asymptomatic. Which of the following are we going to do for him?
We're getting a very large consensus of E. I'm not trying to hedge the bet on anybody though, so don't listen to me.
Just merely reporting the data, Clint.
Correct, and still a resounding E.
A resounding E. That's fantastic. Yep. The point with this question is that any outliers?
Yes, there was one.
Okay. I'll just go through all the answers to make sure that we're all on the same page. But the point with this question is we have a patient who already has a diagnosis. We know that we need to be aggressive about medical therapy for secondary prevention for him. And so if he's asymptomatic, he's not going to derive a symptom benefit from any of these tests. And he's not going to derive a mortality benefit from us doing these tests if we already know that we're going to be aggressively medically treating him. So he doesn't need a cath, he doesn't need a CT, and he doesn't need stress testing for that reason. And a calcium score doesn't really help us because we already know his risk is elevated and we're already treating him with statin therapy. So that's why I wouldn't pick any of these answers for him. But let's say we change the scenario. So we're going to go back to this patient. And he's got chest pain and shoulder pain when he walks uphill during his daily walks because he's being really good about exercising regularly. Then would you change your answer? So I'm going to go back to the question and pretend now that instead of being asymptomatic, he's having chest and shoulder pain on his daily walks. Now what would you do?
I'm going to let a few more answer before I say what everyone is
Okay.
saying. This one's a little bit more mixed. C, B, A, C, A, B, C, A, C, A. That seems to have slowed.
Okay, great. Well, I think that that's a really interesting. The choices would be to do something, and so therefore it's not none of the above. It's not a calcium score like I mentioned for our previous scenario, and so you're left with A, B, and C. So he has known disease. What I left out of the question stem would be, does he have known unrevascularized coronary disease? Does he have optimal medical therapy? And so that helps me whittle down between A and C. In this case, I probably would not pick B, a coronary CT, because this patient with known coronary disease is not at low to intermediate risk. He's already at high risk because he has known disease. And depending on your CT machine and algorithms that the CT can do, the limitations with previous stenting can cause artifact on the CT. And so that's not the best choice to evaluate for someone who's previously had stenting, unless it's a really huge stent. And so that's kind of the exception rather than the rule. So in this circumstance, I would probably opt for C, exercise testing, because I know he can exercise and that's when he's having the symptoms, with imaging to try to quantify his ischemic burden. Because if his ischemic burden is really high, then if he's maximally medically managed, it does make sense to think about proceeding with invasive testing. But if his ischemic burden is very small, and maybe we have room for medical therapy, then that's the best way for us to go for him. So in this case, I think that I would probably go for exercise stress testing with perfusion imaging. And right now, the way that we can go forward with that is with nuclear myocardial perfusion imaging. So recall from the beginning when I set up that really nice table that ways that we can do perfusion imaging, thinking about the ischemic cascade and being high up on the ischemic cascade early, more sensitive. MRI and nuclear imaging are the ways to do that. We can't exercise somebody in the MRI scanner. So right now, nuclear perfusion imaging is what we have. And this gives us a lot of different options: exercise, dobutamine, or a vasodilator like regadenoson to simulate stress or increase coronary flow. This modality is good because we can get both ECG data and imaging data. And depending on the scenario, not in the patient circumstance that I just brought up, but maybe somebody who's coming in through the ER with no known coronary disease, you can get stress-only images or rest and stress images for comparison. So there's several ways we can alter how we image the patients to get the information that we want. And just remember that this is assessing perfusion and relative blood flow. So if there are multiple defects, there are chances for falsely negative studies with multi-vessel disease, because we're comparing relative blood flow with the perfusion uptake. So if we take our patient to the stress lab and image him in this way, what are some of the high-risk findings that would warrant us to be concerned about him? If at rest we see that there's a perfusion abnormality greater than 10% if he had not had a previous MI, that would be concerning. Similar to our imaging with stress echo, if we see stress-induced left ventricular dysfunction, that's an abnormal high-risk finding. Also similar to echo, if we see stress-induced cavity dilatation, or when we do the perfusion evaluation, if greater than 10% of the myocardium is at risk with perfusion abnormality, or similar to echo again, multiple vascular territories involved, those would be high-risk findings that you would want to get us involved. And so MRI is very similar with the exception of the lack of exercise. We get the same imaging data, plus there's the ability to characterize the tissue further. And there's less radiation. We're using gadolinium. So the radiation exposure to patients here is less compared to the other modalities. All right. We're going to switch gears and do another question to stay involved. So this may be where I'm going with these questions. So this is a 58-year-old female. She has hypertension, hypercholesterolemia. She hasn't been taking a statin because she's working on her lifestyle changes, but she's been having some intermittent chest tightness. She comes into clinic. She's like, "Doc, what should I do?"
Stress echo, exercise stress, exercise EKG without additional imaging, exercise stress, C, if you can exercise stress echo, one person has no idea, exercise stress, C, B or C, C, couple more C's. And a resounding B by somebody in cardiology.
Like B with exclamation points?
No, but yes, now they're exclamation points.
Okay.
It's slowing.
Okay, thank you. I think that you can make an argument for both B and C. I'm going to say that I'm the expert consult, so I can't pick that answer. She can exercise, so dobutamine stress testing would not be appropriate, and it would not be appropriate to go straight to cath in this circumstance. So I think really the people that are choosing B and C are right. You could pick either of these tests. And what I would say is that she's really worried. She's worried that this is her heart, and she wants to make sure that she doesn't have plaque. And so for that reason, I would pick B. I would pick a coronary artery CT in her circumstance. And I'm going to talk a little bit about why I would pick coronary CT. One, you get pretty pictures like this. But more importantly, this is a great strategy to non-invasively evaluate patients who are at low to intermediate risk. And that can include both outpatients in clinic and ER patients. It is a great test as a rule out strategy because the negative predictive value of this test is really high. One really great feature of coronary artery CT is that we can evaluate and detect the presence of obstructive coronary artery disease, which is really the question we're trying to answer, as well as non-obstructive coronary disease. So those 20, 30, 40% plaques that are still meaningful from a prognostic standpoint, but are not going to show up on functional testing. And these negative results with CT, if you use it as a rule out, are associated with really excellent prognoses. And there's a lot of data and a lot of trials that have supported the accuracy of coronary CT, both as outpatient as well as in the ER. So when we think about patients who would be amenable and appropriate to evaluate with coronary CT, some of the inclusion criteria I would consider would be no known history of coronary disease, because if there's previous stenting, we can get artifact from the metal. We use contrast, as you can see on the panel A here. And so if somebody's had an anaphylactic reaction to contrast, this would not be the best choice. In general, normal renal function because of the contrast. One other really important feature is that when we image these patients, we would like to get their heart rate down to less than 65 beats per minute, ideally. The slower, the better, because we're imaging a moving target. And so the slower we can get the heart rate, the longer we spend in diastole when the heart is quiescent, and we can get better pictures. And that we can do with medication at the time of the study. For example, though, if somebody's heart rate is going 120 beats per minute in atrial fibrillation, that's not the right person to do a coronary CT on. And so I bring up this study to just show the outcomes for patients who have had coronary artery CTs. So this is a study that Matt Budoff published, and he's really quite well known in the field of coronary CT. This came out already 5 years ago, and it was a prospective multi-center study. They had over 850 patients that were considered intermediate risk with symptoms that were concerning for coronary disease, but previously did not have a diagnosis of coronary disease. They all had a coronary artery CT, and they followed these patients for over a year after their CT. And the patients who had a coronary artery CT that was negative are the line up here with the triangles. And then those with the circles were down here. Those are positives. And so this is where we get that really high negative predictive value and the really low outcomes for patients. So they calculated major adverse cardiovascular events. So that composite outcome we're all familiar with of cardiac death, non-fatal MI, unstable angina. And over the year, the patients with a negative CT had a 0.1% chance of having those events. 0.1% of those patients had an event. So an excellent prognosis if you have a negative coronary artery CT. And then if you think more about outcomes of patients, which hasn't been the way that many stress testing studies have been done in the past. Most of the studies have been looking at accuracy, comparing to our invasive standard of coronary angiography. Now we're seeing a movement to look at outcomes for patients with different testing strategies. And so this is data from the PROMISE trial, which came out in 2015, so also 5 years ago, looking at outcomes of patients who were tested with an anatomical strategy, coronary CT, or functional testing with stress testing. And that included both stress echo, stress nuclear, and ETTs. The majority were stress nuclear. And this is the Kaplan-Meier curve for the composite endpoint. And so anatomic testing and functional testing were very similar. So there was no detriment to using an anatomic testing strategy for patient outcomes. It did just as well as the functional testing. And then another really important trial that looks at outcomes with coronary CT and patient risk going forward is something called the Scott Hart trial. And this was published recently, their 5-year outcomes, just in the past year or so, looking at 5-year risk of MI with coronary CT as the strategy versus standard of care. So that could be whatever the physician decided to do, whether that was stress testing without imaging, stress testing with imaging, they could pick any of them. And the initial study results looked at certainty of diagnosis. And then they followed these patients over 5 years worth of time. They were able to reclassify patients' risk based on CT data. And the CT was able to help cancel invasive coronary angiography for patients who didn't need it after stress testing. But what was really powerful, I think, was following these patients for the 5-year time point and looking at death from coronary artery disease or non-fatal MI. The standard of care group had a 3.9% cumulative incidence over that 5-year follow-up period, compared to 2.3% in the CT group. And if you just look at non-fatal MI, there still was a difference in standard of care versus CT, with CT being lower. So by using CT as a strategy, these patients still had a lower risk of death or non-fatal MI. And beyond that, now what we can do with CT is provide functional data on top of anatomical information. So there are some protocols that will allow you to do stress perfusion with the CT, but I think more widely in clinical practice is the CT-FFR. And what that stands for is fractional flow reserve, or a ratio of flow in a stenotic coronary artery. And we can use our coronary artery CT data set that we acquire with the axial coronary CT images and send that to get an analysis non-invasively of flow down the coronary tree. And this uses some really high-level math and computational fluid dynamics to get these values. But this has been validated and compared to invasive coronary artery evaluation with FFR. And it's not perfect, but it's really, really good. So this strategy of testing with coronary CT, plus the ability to get functional data, can be really powerful to help rule out coronary disease in patients, and then to pinpoint patients who are at higher risk by looking for left main disease or by multivessel abnormalities with abnormal FFR. So high-risk findings on CT, if you get a CT report back, would be certainly very high coronary artery calcium scores, multivessel disease, or left main disease. And very briefly, I just want to mention the CAD-RADS scoring system. This was published in the Journal of Cardiovascular CT as a standardized reporting method so that cardiologists and radiologists who are reading CTs standardly report the stenosis level and to help provide risk stratification. This is similar to mammography and how radiologists report findings there. And there is a CAD-RADS reporting system for stable chest pain. It goes from 0, 1, 2, 3, 4, 5, or non-diagnostic. And there's also a reporting system for acute chest pain. So for example, somebody comes into the ER. Again, similar 0, 1, 2, 3, 4, 5, and N. And not meant to read all of this here, but just to be at least familiar with the fact that once we give a degree of stenosis and make an interpretation on CT, there's actually a management recommendation that comes with it. Okay, I think we have time for maybe one more quiz question. So I'm going to pull that up very briefly. Oh, it didn't like it. So we're going to do it this way again. Okay, so this is a 49-year-old man. I saw him in clinic recently. He likes to bike to work, but started having some increased dyspnea biking and then some indigestion. So now, after having gone through all of our test modalities, what do you think would be the optimal test for him?
We're getting a couple Ds, a B, CCTA, B, 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 CT, CT, D. So it's a kind of a mix between B, D.
Okay, smattering. I would volunteer that I would probably pick a coronary artery CT. He's got some kind of squirrely symptoms. They're a little atypical. Maybe indigestion is really angina. That certainly can be the case. He's still able to bike. He's just more short of breath biking. And if the question we're trying to answer is, does this man have coronary artery disease as a cause of his symptoms? I think then, based on the data that I've shown and other data, that coronary CT is the best test to answer that question. And so it can help us, in addition to making that diagnosis, guide treatment. It can also be really powerful to bring up an image like this and show that patient, look, I know you're having these symptoms. I believe that you have these symptoms and they're from something, but it's not your coronary arteries. So this is an example of a coronary artery. This is in fact the right coronary artery, so aorta here. And we can display the coronary artery kind of in a two-dimensional way, even though it's a three-dimensional structure, in a curvilinear format like this. And it's completely full of contrast, normal, smooth, zero calcium. And I think it's very reassuring and powerful for patients to be able to see that, to rule out coronary disease in a way that it's easy for them to see and understand. So we've talked about a lot of different test modalities today, and maybe I confused you more. That's not my aim, but my goal was to help show you that there's ways that we can pick different tests. And even though it's challenging, we're trying to pick a test that's going to improve our patient's outcome. We can choose between functional or anatomic testing, depending on our scenario and depending on what we're trying to do. And each of those modalities can be have pros and cons, and it depends on the patient. So medicine is an art, so it's not always going to be picking CT every time, and it's not always going to be picking stress echo every time. And that's why we see our patients and talk to them. But I think we should be thinking about doing a CT first strategy. And this publication came out in JACC just recently, within the past few weeks. And it's a really, really simple and straightforward short article that I think would be quite worthwhile reading. And again, it highlighted some of those trials I showed, the Scott Hart trial, reduction in death and MI by using a coronary CT strategy, and improving patient adherence to medical therapy. And the reason for this is that it answers our questions. It answers, do we have coronary stenosis? It answers, is there high risk blockage? Is there plaque? How much? And helps drive medical therapy, lifestyle modifications, and then it can provide even more useful information. So high risk plaques, or maybe there's other pathology in the chest that we see, like pericardial disease you weren't expecting to find, or pulmonary disease, because that's part of the CT scan as well. So I think a CTA first strategy is something that we really should be moving more towards. And one of the things that we're going to need to do is to make sure that we have reimbursement for it. And the CMS is trying to cut reimbursement for CT. So my plug is to just comment and let them know that we want CT to continue to be reimbursed, because that's going to drive our testing as well. So I hope as a result of this lecture, we've thought a lot about when stress tests are appropriate, who should not have stress tests, what other non-invasive tests can I order, that you've gained a little bit of knowledge about the differences and contraindications for types of non-invasive testing, and some knowledge of how to interpret those stress tests and what high-risk features really should get cardiology consultation involved. And I just want to say thank you for the opportunity to listen to me speak today, and I would be more than happy to answer any questions.
Thank you, Dr. Reilly, for a wonderful overview. I think my take-home message from all your case presentations is I shouldn't exercise, because that's where they're all getting in trouble.
No, good, please exercise.
I do have one question that you just touched upon at the end. What is the cost comparison of the different modalities that you mentioned? So what is the finances of it? And I guess the second and third part is, what is the length of time required for each of those tests and the expertise needed for those?
Oh, I think that's a great question. So the length of, I'm going to start with the second part of your question, the length of time. So for a stress test, if somebody is going to exercise, most people complete their exercise and don't go on the treadmill much longer than 10 to 12 minutes. Now, there's some exceptions to that. So the actual exercise portion is relatively short. If the patient is getting imaging, whether that's nuclear imaging, echocardiographic imaging, that will affect the duration. So with echo, you'll get images before exercise and then after exercise. So kind of all encompassing, maybe an hour's worth of time. For nuclear testing, because the perfusion images are spaced out based on the radiotracer doses, that tends to be a little bit longer, more around 3 hours worth of the patient's time, just with some of the waiting. Coronary CT is shorter than that, so depending on what the patient's heart rate is coming in, they may not even need medication to slow them down like metoprolol. So they might be able to get imaged right away. Typically, we have our patients come in about 90 minutes before their scan time so that there's adequate preparation. And then the scan itself takes just a few minutes. We do the non-contrast calcium scan and then scan itself with the contrast. So only a few minutes worth for the scan itself. And then the first part of your question was the expertise needed to evaluate each of these studies. And I think that's a great question, and one that is probably why some of these payments are being reduced or proposed to be reduced, because what happens with CT is it gets lumped into just general CT, and coronary CT requires additional protocoling in many places where the CT scanners are not the high slice, like 256 slice CT scanners, will need to image the heart in multiple different heartbeats. And so that requires someone really to be at the scanner in terms of timing for the contrast bolus and making sure everything is covered appropriately. So that level of expertise requires additional training in fellowship, imaging fellowship. And then with stress testing too, I mean, you have to be able to go through a certain number of cases, and we outline that in our COCATS requirements for fellow training. So the expertise involved is high, I think, as long as you've done it many times throughout fellowship and continue to do it and maintain it.
And then the cost of the different tests?
So I think the cost of the different tests is going to be different, and I don't know the actual numbers in that in terms of our data, but it will vary as well about insurance and insurance reimbursement.
Okay. What is the role of exercise EKG without imaging? Is that still the recommended first-line test for average risk situations?
I think that the role of exercise ECG is probably less now than what it has been in the past. If you have somebody that you're trying to answer the question, do I have coronary disease? I really think that the CT first strategy is going to be the way to go. They can exercise, and yes, that exercise information is powerful. Exercise stress tests are not 99% sensitive. The negative predictive value is not as high as the coronary CT. And so when patients come in and say, my dad died of a heart attack at 61, I want to make sure that this chest heaviness isn't my heart, I'm going to feel more reassured by the data CT provide rather than saying, okay, you exercised and it was fine, you're good to go. I think the data from CT is much more powerful.
Great. And we're running out of time, so I'm going to pick one last question because this comes up all the time. We get a CT for something unrelated, and there's calcium in the coronaries, incidentally detected, not on a a cardiac CTA. What do? We ignore it. We send it to you.
That's a great question. That definitely comes up all the time. So basically, because those studies are not gated and the heart rate is not controlled, really what we're able to say is that yes, there's the presence of coronary artery calcium. And that's helpful because we can say there's calcium there. So I would not ignore it, one. And I would say that that is an additional tool that you can then use to your patient and bring it back to him or her and say, you have calcium, let's talk about primary prevention and really make a push for statin therapy for that patient.
Okay, great. Well, thank you so much for a wonderful overview. Thank you, everybody, for all of your questions. Sorry we couldn't get to them all. I'm sure Nicole would be happy to take your questions afterwards by email.